Good morning. Good morning.
Right, sir.
You're welcome to today's lecture. We are still on the topic, on the course, Basic Dispensing Theory 1. This marker is not. Basic Dispensing Theory 1. We are still on the course, Basic Dispensing Theory 1, BDT 152. And the topic is still suppositories and pessaries. These are our second contacts. Suppositories and pessaries part 2. In the last lectures, we introduced suppositories and pessaries, and we defined suppositories, general definition, and pessaries. We also discussed the BP, British Pharmacopoeia definition of suppositories and what? Pessaries. Then we now went forward to discuss the advantages and what? Disadvantages of what? Suppositories. Then we also talked about the types of suppositories and their what? Dosage form what? Characteristics. Then we talked about the shapes of what? Suppositories, and we discussed the therapeutic uses of what? Suppositories. So then we also talked about the right location of what? Suppositories. It should be a kind of in the middle, not too high, not too low. So in today's lectures, we look at the factors affecting what? Drug absorption from what? Rectal what? Suppository. As we discussed when we introduced dosage forms, we say that the dosage forms are what? Formulations of what? Drug. Formulations of what? Drug. They are also known as what? Medicines or what? Drug products. So the idea of formulation is that these products will deliver the what? Active what? Ingredients or the what? The drugs to the site of what? Action. That's the basic need for formulation of what? Drugs in dosage what? Form. So if after formulation of drug in dosage forms, which suppositories and pessaries are one of those what? Dosage forms. If after formulation and the drugs inside the suppository or pessaries find it difficult or is unable to leave the suppositories or the pessaries and enter the system, be it for systemic what? Action or leave the suppository or pessary to effect its therapeutic what? Purpose on the particular location, then it is of no use. True of us. It is of no use. The drug should be able to leave the suppository or pessary before it can exact what? Its what? Therapeutic what? Activity. That's why, remember when we said that, I give you an example that if someone now swallow, when we discuss tablet, that if you swallow tablet on getting to the stomach, the tablet ends up not disintegrating. You end up doing what? Passing it through your what? Anus. If let's assume the drug is paracetamol, you will see you having the headache. Because the paracetamol did not leave the what? The what? The tablet. That it means, what it means is that what they formulated is of no use. Because the idea is that this tablet should deliver the paracetamol. So the headache will still be there. The fever will still be there. Because the paracetamol did not leave. Even though you ingested or you took the what? The medicine. But the paracetamol did not leave, find it difficult to leave because of how they formulated it. So that will now lead us, this is a way of introduction for you to understand what we mean by factors affecting drug absorption from what? Rectal suppository. So there are different factors that will affect whether, that will determine whether the active ingredient, let's assume bisacodyl suppository. The bisacodyl itself, there are these factors that will determine whether this bisacodyl will leave the suppository and enter the particular location or whatever to exert its pharmacological, therapeutic actions. Now, these factors are categorized into what? 3. What is this? These factors are categorized into what? 3. We have the physiological factors. We have what? The physicochemical properties of the what? Drug itself. And we have what? The physicochemical properties of the what? The base and the what? Adjuvant. Now, when we say physiological factors, we are talking about you know, remember I told you that the importance of, I give you the importance of some of the courses you are doing. Biology, physiology, anatomy. You have to study the body of human body and the body of living organisms, because this is where these drugs are, 3 of us. So what happens in your system also affects how the drug leaves the what? Suppository to enter the system. Am I completing? So these are categorized under what? Physiological what? Factors. Then when we talk about physical chemical properties, it talks about the physical and chemical properties of the drug itself. You know, in fact, you have the thing that has to do with the what? Human body, and factors that have to do with the what? The medicine itself. Under factors that have to do with medicine itself, we have factors that have to do with the drug itself. Because the drug contains the medicine, the base, and the adjuvant. Adjuvant composed of other excipients in the what? Formulation. So that's why we have physicochemical properties of the drug itself, and we also have the physicochemical properties of the what? The base and the what? Adjuvants. Are we together? So these whole factors determines the release of these drugs from the what? The formulation. Now, let's look at physiological factors. Under physiological factors, we have these factors like colonic what? Content. We have factors like what? Colonic content. We have factors like what? Circulation. And factors like what? The buffering capacity of the what? Rectal, the pH, and the buffering capacity of the what? Rectal. Have you done buffer solution? Yes. Good. So you know what buffer solution is. Yes. Have you not seen why I said that? If you don't know what buffer solutions are, if I say buffer solution, you're confused here. Thank God you have done that, so it makes the work easier for me. I will not go down and start teaching chemistry. Hallelujah. So let me now go straight to the point in teaching chemistry. I like that. Now, so before you talk of the physiological factors, you need to understand one or two things about the physiology of the particular region involved in this what? Absorption. Where? The GI, right? Rectum specifically, right? Good. So now let's look at how human rectum is. Basically, human rectum is about 15 to 20 cm in what? Length. Are we together? Sometimes it can be empty, sometimes it can contain fecal material. Maybe after eating all this, you are before you defecate. At that point in time, your rectum is filled with what? Fecal material. So that fecal material, there has effect on the drug absorption. If you are using what? Suppository. Am I communicating? Yes. So when empty of what? Fecal material. Now it also contains 2 to 3 ml of what? Inert what? Mucus what? Fluid. 2 to 3 inert ml. Physically male. But in resting stage, the rectum is what? No. You know what it means, right? Yes. No movement, right? Yes. Good. In resting what? State. It has no villi. Neither does it have microvilli. Know that point. So what does it mean? Does absorption take place there? Does it take place there? Are you sure? Are you sure it doesn't? Absorption doesn't. So how then will the drug enter the system for circulate for systemic action? Find out if absorption takes place in the rectum. Find out. Assignment 1. Find out. You tell me this one.
Yes, absorption takes place.
I say find out. I didn't say you tell me now. Find out. Find out. All these people I'll be giving assignment. None of them has ever come here to talk about it. And I told people to remind me. You kept quiet. That means you're hiding them. No problem. Keep hiding them. Where is Ada? Don't worry. This one, Adobe.
I'm not glad I said it.
He just said they just ask me. I say you come and tell us about this one. Rectum, whether it truly has microvilli or villi. Then secondly, whether absorption takes place there. You tell us. You teach us that one in our next class. So make research on that. Serious research. I'm going to call her. If she end up being like this, maybe the thing escaped my mind. Remind me. And if you don't remind me, you do it. Alright, let's continue. Okay, now so I've mentioned these physiological factors like colonic content, circulation, pH, and buffering capacity of the rectal fluid. Now let's look at the colonic content. Let's look at the colonic content. What do you understand by what? Colonic content. That is content of the colon. Content of the colon. So content of the colon also affect what? Drug absorption from suppository Are we together? Good. Now, I said something about. Hello, are we together? I mentioned fecal material. That is feces, right? In the rectum, right? In the colon. I mentioned fecal material. Now let's look at this. Remember, we said that suppositories can be used for their systemic effect or local effect. Now, for systemic effect, when systemic effect is desired, now there is greater absorption in the rectum when it is void. You know what is void? When it's empty, right? When it's empty, right? Yes. Good. There is greater absorption from where? Rectum. When it is empty. When it is void, which means empty, right? Good. Now, but when it has fecal matter, that is feces, then absorption will do what? Is what? That's why sometimes when a patient needs this suppository and there is maybe fecal matter in there. Now there's what is called You know, sometimes you may not want to poop. Are you aware? Yes. Sometimes there may be fecal material there, but it hasn't gotten to the extent to start eliciting what response for you to poop. Hope you know.
Yes.
That you are not pooping doesn't mean that there's nothing there. Sometimes something can be there. Are we together? But it hasn't gotten to the limits that will do what? Stimulate you to do what? Want to do what? Poop. Now, in that situation, where the patient needs to take this to be administered this drug, and truthfully there is fecal material there, what do we now do? You remember we did enema, right? Where do we use enema? Where do we use enema? Do we drink it?
No.
So do you apply it on the skin? Good. So there's what is called evacuation what? Enema. Evacuation enema may be administered. The idea is to do what? Remove the fecal material. Okay? So when that is done, then the suppository can now be what? Administered. For optimum what? Action. Okay? For optimum therapeutic what? Action. So if it's there and you insert, the activity may do what? Do what? Decrease. Are we together? Yes. Apart from that, diarrhea can cause it. Diarrhea can also affect what? Absorption. Diarrhea can. You know what diarrhea is? What causes the diarrhea? What actually causes the diarrhea? Do you know? Do you know? As in basically, I know there are factors, but basically what actually happens in the diarrhea? Basically, you know what enters the what from the small intestine. What enters from the small intestine to the large intestine is what? It's in form of fluid, chyme, right? Is it chyme or chyme? What do you call it? Is this chyme or chyme? CHYM. Is it chyme or chyme? So forget the point I want to make is that what enters the large intestine is water. It's water. It's from that large intestine that the greater absorption of water takes place. So that's why what leaves the large intestine will not become solid down to rectum. So when there is problem in that absorption around that large intestine, then what will come out is water. Watery stew. Am I completing? So anything that will affect absorption of that, taking away that water from that, everything that leaves the small intestine to large intestine, then the person will poop water. Mixture of whatever, what did you water, because that water that was supposed to be taken away was not what? There are many factors that can lead to that. So I'm not talking about I don't want to go into the pathophysiology. I'm just telling you exactly what happened, the summary of what happens there. But this is not physiological class, okay? Now when you enter physiological class, you do that, okay? Now, so now when there's diarrhea, there's problems. It will affect the what? Absorption. You know, anything water is washing away. Wash. Two of us, erosion. Wash it. It will clear everything. So there's issue. It will affect the what? The what? Absorption. Now, also, colonic obstruction. When the colon is what? Obstructed, it also affects the what? Then tissue dehydration. Then another point is that the rate and degree of drug. Okay, sorry. This factor, diarrhea, colonic obstruction, and tissue dehydration, they affect the what? Apart from fecal content. Apart from what? Fecal material. Apart from fecal material, we have diarrhea, we have colonic obstruction, then we have tissue what? Dehydration. Now, what happens in circulation? What happens in what? Circulation. Remember yesterday we discussed, I asked when we discussed advantages of what? Suppository. Remember? We discussed remember we said that it's very good it can be used to formulate drugs that are susceptible to what? First pass what? metabolism, remember? So to bypass the liver, then you can use such drug. Even though it will bypass it, but it may not be 100%. It may not be 100%. When a drug is formulated as suppository and they administer, about 50 to 70% of the drug will bypass the liver. Therefore, avoiding first pass degradation or first pass effect. Am I completing? So, drugs that are absorbed rectally, partially bypass portal. When you say portal circulation, it means the liver, the blood that enters the liver and going into the liver and going out of the liver. So that's anytime you hear portal circulation, it has to do with circulation in the liver, entrance, and whatever happens, and the blood leaves. So that's what we mean by bypassing portal circulation. So drugs that are rectally absorbed partially bypass portal circulation, thereby preventing destruction in the liver. So if they bypass the liver and they get to the systemic circulation, wow, they will become survivors. True of us, they will not be enough quantity of the drug to exert the therapeutic effect. True of us. But when they enter the portal circulation, then there will be a problem. They will be destroyed, and you will not have enough that will exert the therapeutic effect. So having known that it may not be all of them that may bypass it, this will also inform the amount of the drug that will be used in the formulation. Because at the end, the only active drug in the system is the one that is biologically available. True of us. Have you done bioavailability? Bioavailability. Yes. So the only one that will exact effect is one that is biologically available in the systemic circulation. It's not the amount inserted. So having known that not all may bypass, some may not bypass, about 50 to 7% might bypass it, if we inform the decision on the amount of each of them to be used. You determine the amount of them that will be that will be incorporated in the formulation. Now, so that's exactly what happens. So remember I told you we discussed the height of insertion. Remember, the height of insertion. Not too high, not too low. So, if it is too high, okay, let me not talk. If, depending on the height at which the absorption occurs in the rectum, the drug passes. There are three branches of veins that the drug will pass through. We have the inferior, middle and superior hemorrhoid vein, depending on how you put it. So the inferior hemorrhoid vein is nearest to where? The anus. Okay? But the superior hemorrhoid vein is near to portal circulation. If you like, it will enter superior hemorrhoid vein. So what will happen? It will get to where? So these are the things you put into consideration. That's why we discuss being too high and being being too low, fine, inferior, but there's tendency for you to do what? Drop out. True of us. If it's too low, if it's very near to the end of it may fall off. True of us. So you should target the middle. Now, it is advisable, because of this now, it is advisable to do what? Keep suppository in the lower part of the rectum. Did you hear anus? Lower part of the rectum. Not higher up that we enter through the superior hemorrhoid vein and enter portal circulation. Not too low towards inferior that it may even fall off, but lower part of the rectum. Now, I think I've mentioned that about 50 to 60% enters what? Bypass the what? Rectal, portal what? Circulation. Good. Now, that's for what? Circulation. Now let's look at another physiological factor. Here we'll talk about, let's look at the pH and the buffering capacity of the what? Rectal fluid. Thank God you've done pH. Hey. So it will be easier for us, right? Good. Yeah, and we have done buffer solution, right? So let's continue. Basically, rectal fluid has pH around 7 to 8. pH around 7 to what? 8. Is considered what? The rectal fluid is considered generally what? Neutral. Generally what? Neutral. What are buffer solutions? What are buffer solutions? Chioma, what is a buffer solution? You don't know. Keep quiet. Kennedy, what is buffer solution? What's the buffer solution? You don't know. Divine, what is buffer solution? Was this taught in this class? Yes. So what's going on here? Sarah Maris, what is buffer solution? You don't know. Jinaza, what's buffer solution? You don't know. Amma, what is buffer solution? You don't know. And Chukwemeka, what is buffer solution? Oh, you take here. No. Oh yeah, answer. Solution that does what?
Resist change the pH.
Yes. You go far. So it resists what? Changing what?
pH.
Look at this one. How they are late today. If I were you, I would fast for coming late to class.
Eh?
I will do mea culpa for coming late to class, not to late. All right, so now let's continue. So now one thing with this rectal fluid cannot resist this. Changing what? Yes. Am I completing? It's not what? Buffer. It has no effective what? Buffer what? Capacity. Are we together? It has no effective what? Buffer what? Capacity. Now, what effect does this have? What effect does this have? Remember, did you do anything about? I don't think you. No. You not do it at this stage. This is purely from stick thing. About ionized and what? Unionized. Actually, if you go to the GI, if you go to the mucosa, you know how this absorption takes place, right? This assimilation takes place, right? You know how this leaves the lumen to the blood stream. You know now, right? How? This nutrients generally, drugs, what have you, leave the lumen into the what? The lumen of the what? The the GI now into the what? Blood synthesis. Do you know how it happens? How does it happen? You don't know. Say the one you know. Let me hear you. Be confident in yourself. Well, say the one you know. Let me hear you. Through what? Transpiration. Transportation. What you say now is more complex. You are talking about transport, active, and not that level. Huh? Any other idea? I want to make this class interactive. You already have this, so you have read it, right? So I don't want to be telling you again what you've read. I want to hear from you. What do you think? So some people are not thinking. Eh? Now, what is the difference between vein, venous, and capillaries? Vein, venous, and what?
Capillaries.
Capillaries. Artery, arterioles, and capillaries. So what? Do you know what this is all about? Yes. Who said yes? Tell us. Oh yeah, fast. I'm combining physiology now. But let's go ahead.
All of them, they are blood vessels.
Good,
But veins are bigger, they are wider than the venous.
Okay.
And then the veins are bigger than the capillaries. Capillaries are the tiniest blood vessels.
Okay.
Why artery is bigger than vein? Artery is the biggest, it's bigger than vein. Then arteries.
No. Don't compare. This is don't follow here. Treat them like this and this. Don't compare like this.
Arteries, they are the biggest blood vessels we have. It's not the biggest.
Don't say biggest. Don't say biggest because iota is there.
Yes, biggest is iota, but artery is bigger than vein. They are like seven.
You are still comparing two of them. I mean.
Okay, they are the.
So what? Okay, thank you very much. Thank you. What happens at the capillaries? Huh? Capillaries.
No.
So I mean, what happens at the capillary level? That's what I want to hear. These arteries, you get down to what? Arterioles. Then the arterioles come to each part of the capillary bed. Hope you know. Just if this is artery, if you branch to what? Arterioles. I would get that smaller one, right? Which branch to what? Form part of what? Capillaries. Form part of capillaries, right? Then also some part of capillaries is formed from where? Contributed from where? Venous. So venous and arterioles and the arterioles, they interact at this what? Capillary bed. And they come out drain as what? Venous, which continues as what? Vein. So at this capillary bed, what happens there? In most organs and part of the body, even in the GIT, this is where, God bless you, go far. This is where it is. Even in the lungs, this is where, if you go down to the alveoli, that's sac. This is where you have capillaries. Anywhere you see capillaries, there's exchange. Nutrients entering, going out. Oxygen entering, going out. Am I completing? Good. Carbon dioxide going out. This happens at this one, capillary. Now, when this thing enters the what? When this what is it called? This at the lumen of this, if we have the just as you are, the food you eat, the nutrient leaves and enters the bloodstream, the same way the drugs itself enters the what? The bloodstream. And how do they not enter the bloodstream? What form? You know, sometimes these drugs, you don't acid, base, and salt, right? Right? Good. We have salt. Salt. Sometimes most of the drugs exist as, even though you can have those in their base form, those in their what? Salt form. Now, but basically, there's this ionization. There's some part of the drug that may be ionized. Some may be what? Unionized. The part that is absorbed readily is what? Unionized form of the salt, of the salt. That's the one that are what? Absorbed readily. To compare with what? The ionized form. So now, this lumen, this absorption from the luminal part of the what? GI to the what? The lumen of the what? Bloodstream favors that word favors absorption of what? Unionized form of the what? Salt. Is the unionized form that is what? Favored. Now, because the rectal fluid have very low buffering capacity. What it means is that it cannot resist changing pH. So, if it cannot resist changing pH, you can formulate the drug in such a way that the pH it will generate there will favor unionized form of the drug. You can formulate in such a way that the unionized form of the drug will be favored more, so that more of the drug will be what? Absorbed. Am I completing? Now, have you now seen how the pH and the low buffering capacity of the rectal fluid can affect the what? Absorption of this drug. Anything you will do that will increase the unionized form of the drug will enhance what? Absorption of the what? The drug. But anything you will do to produce more of the ionized form of the drug, absorption of the drug will be what? Low. Are we together? Note this point. So this is how this will do what? Affect. So you can actually work on it. You can remember pharmaceutics is the what? Science of what? Dosage form design. These are things you put into consideration before you can. We call this biopharmaceutics. Biopharmaceutics. You are not just working on the drug alone. You are also considering the biological system. Am I completing? Under pharmacy, you also have an area specifically called what? Biopharmaceutics. You look at the biological system, know how you can use it to do what? Work on the design of whatever you want to what? Deliver to the what? Biological what? System. So that's how the pH and lack of what? Buffering capacity of the rectal fluid can affect what? Absorption of drugs from the what? Rectal what? Suppository. Now, we are done with what? Physiological what? Factors. Now let's look at physicochemical. If you have a question, please feel free to ask. Let's look at the physicochemical characteristics. Of course, I've discussed this in this class. By physicochemical, we are talking about physical and what? Chemical properties of the what? Drug itself. So how does the physical and chemical properties of the drug affect the what? Absorption of the what? The drug. Now, what I discussed about unionized and ionized form of the drug, if you understood what I explained there, it forms part of this what? Physical properties of the what? The drug itself. Now, here we are going to look at three factors. We are going to look at three factors. The first one is what? That's what is called partition coefficient. The lipid water partition coefficient of the what? The drug itself. That's what I will explain. The lipid water partition coefficient of the drug itself. One factor. Second factor is degree of what? Ionization of the drug itself. How, by the time we enter second year, you appreciate this thing very well. We're going to start doing farm camp. So I'm preparing you for farm camp now. So hello, let me now tell you something you need to know. If you play with suppositories, you may have issues in 1 5. So if from the first week, we have been gallivanting around tablets, so we have exhausted a lot of things in tablet and granules and capsule. Suppository will form up to 60 something, call it 60% of questions you will see in your exam. So don't joke with it. Are we together? Suppository will form 60% of what you see in question. Capsule will form 10% of your exam question. Then the remaining 30% of the exam question will come from where? Tablets, granules, powders. Note these points. So don't joke with suppository. If you know, you see, that is the most what? The volume is small, true of us. So don't joke with it. And no question so far from it. So this will be a part of your question from exam will come from. Now let's continue. So partition what? Coefficient. Then we look at what? Degree of what? Ionization. And also the concentration of the drug in a base. These are three factors. These are three physicochemical properties of the drug itself that will affect the absorption of drug from the what? Suppository. Are we together?
Yes.
Good. Now let's do this. Let's go back to what? Partition. What is partition coefficient? You know, these drugs, some of these drugs, some of them may be more soluble in water and less soluble in what? Lipid. Less fat soluble. Then some of them may be more fat soluble and less. So how this a particular drug partition itself, how soluble it is in lipid, in fat to compare with water, gives you what the partition coefficient of that particular what? Drug. Am I completing? There are some of them that are more soluble in what? Water, less in what? Fat. So every time you hear partition coefficient, you see how a partition itself between water and what? And this will affect how it leaves the dosage form. You know, when we do base, you will find out that there are some suppository bases that are liquids, water, hydrophilic. Some are what? Hydrophobic. Now, if the drug inside the suppository, for it to leave the base and enter the surrounding fluid, in the rectal fluid, then you have to consider how it partitions between water and what? Fat. It's very important. If that particular drug is lipid soluble and you use a fatty base, you will realize that the fatty base will hug it, the drug, and they will remain in there. It will be very difficult for it to release it to the surrounding fluid. Three of us, they remain there. But if you use if the drug inside is more is hydrophilic and the base is fatty, they are enemies on their own self. That drug is waiting to leave that place. It cannot stay. Two of us, it can't stay. So any small thing outside, it will leave. It can partition, leave that place and enter the what? The surrounding water. That's what happened. Am I completing? So have you now seen how the physicochemical property of the drug itself will affect how it partitions, how this can happen? Now, having explained that, let's go down to what we have here. Now, we have lipid water solubility of a drug, or simply what? Partition what? Coefficient. Now, the lipid water partition coefficient. The lipid water partition coefficient of a drug is very important in selecting the suppository what? Base. And in anticipating drug release from the base. In anticipating drug release from the base. So now, let's go to that lipophilic. You know what lipophilic drug is now? Philic means love, liking. So lipo means lipid. So drug that likes what? Fat. True of us? That can dissolve in what? Fat. So lipophilic drugs, in other words, distributed in a fatty. Listen carefully. You know, we are preaching here. So we are reading as if I'm reading the scripture. So try to reason with me and understand it. I know why I'm doing this. So from my experience in teaching, some students find it difficult to even read and understand. Some not even know how to read. That's why I'm doing this. So follow me line by. I've explained it, I would have passed, hope you know, and go my way. But I said let me just do it so that when you are going through it, you will understand it better. Now, so for lipophilic drugs that likes what? Lipid, right? Can dissolve in what? Lipid. In fat. Lipophilic drug, listen carefully. Lipophilic drug distributed in fatty suppository base. The drug is lipophilic. And you now use a fatty base to do what? Formulate it. See what will happen. Lipophilic drug distributed in fatty suppository base has fewer tendencies to do what? Escape. To surround. Why will he escape? What they have hugged each other and they remain there. He can't escape now, two of us. He can't escape easily now. So if you be careful about the type of base you are using for a particular what? Drug. That's the what? That's the what? That's the message. Am I completing? Yeah. As you are choosing the base you want to consider the drug you want to do what? Formulate. Is that what you want? Know exactly what you want. So lipophilic drug, in other words, distributed in a fatty suppository base, has fewer tendencies to escape to the what? Surrounding skew what? Lipid. Now listen carefully. Thus, water-soluble salts are, listen carefully, water-soluble salts are preferred in fatty base. So, water-soluble salts are preferred in fatty base. Because the fat and the base, and the water-soluble drug, and the base that is fatty, go first. They can't even stay. The drug is like this, waiting to leave the what? The what? Suppository. The base is like, even though they are mixed together, but they will not do what? You can't hold it. Any slight difference in solubility, it will go. It can easily do what? Release. And you go and do its work. But the lipophilic one in fatty base, they can use that they sent him to market. When he now saw where they're playing game, he joined them as I playing game. That's how the lipophilic drug in fatty base looks like. Because releasing, even if release, the release will not be much. So even if you have no choice, of any other base, it must be fatty base. This will inform you the amount of the what drug to be incorporated, so that no matter what happens, you can get some reasonable quantity that can be what go out. Are we together? Now, so the summary is now clear that water-soluble salts are preferred in what? Fatty what? Base. But what of water-soluble base? Listen carefully. What of water-soluble base? There's a difference now. There's something that happens when the base is what? When the base is what? Hydrophilic. When the base is water-soluble, something happens. Watch out. For water-soluble base, example, PEG. PEG is what? Example of water-soluble base is polyethylene what? Glycol. For example, now, if PEG is used, PEG is water-soluble. Now, watch out. Water-soluble base on its own dissolves in rectal fluid. On its own. Good. It can easily release both water-soluble drug and oil-soluble drug. Do you know why? Now, let's start with what? Lipophilic drug. If water-soluble base contains lipophilic drug inside, they cannot hug each other. Two of us. Even though you can mix the body, it cannot hold it. Two of us. It can easily be what? Release. If lipophilic drug is in water-soluble base. Now, normal, it can go on its own, right? Now, but if lipophilic drug, hydrophilic drug that dissolves in water, is in hydrophilic base. You expect that they will hug each other, right? Yes, it will allow you to go. I agree. But the base itself is soluble in the rectal fluid. Yes. So what will happen? Everything will still do what? Dissolve. And it goes its way. Is it clear? Yeah. This is what happens. So what it means in summary is that fat, water-soluble base can go for both what? You can use it effectively for what? Hydrophilic drug and lipophilic drug. But if you are using hydrophilic lipophilic base, that is fatty base, go more for water soluble drug, unless you have no choice. Then you cannot know the amount to use and everything. These are things you do in your calculations. So have you not seen how the partition coefficients of that drug can affect its release from where? Suppository base. We are done with this. We have a question asked. Now, the B part is what? Degree of ionization. We've talked about this before. I have explained this. So, but let me just say it again. Degree of ionization. What is the extent of the ionization of that drug? If the drug has a complete ionization and you use it as formulated, there will be issue, true of us. Because the one that we favored more is unionized form of the drug. So the degree of ionization of the drug is important. So if the drug, but you can work on it. Remember how you can work on pH so that it can yield more of the unionized form. Now, let me read it again line by line so that it will make more sense to you. Degree of ionization. The barrier separating the colon lumen from the blood. Colon lumen, blood. The barrier. You know that this barrier is barrier of this capillary. Hope you know. Yeah. Hope you know the wall, the capillary wall. Hope you know. So it can easily leave the colon and enter the what? The drug can enter the. But the one that will favor that will enter more is the unionized form. Now, the barrier separating the colon lumen from the blood is preferably permeable to the unionized forms of drugs. Therefore, absorption of drug would be enhanced by what? Increasing the proportion of what? Unionized. So it's not left for you to know how to formulate, do a lot of things, manipulate everything to ensure you have more proportion of what? Unionized form. This is what you do in gymnastics. You keep looking on how to do researching, what to do to this thing now, so it can produce, you can have more proportion of what? Unionized form. Because unionized form is preferably what? Absorbed than the ionized form. Are we together? Are we together?
Yes, sir.
Are we sure?
Yes, sir.
Now, let's look at concentration of the drug. Another factor. Concentration of the drug in the base also affects the what? Absorption of what? The drug from the what? Rectal suppository. Now, concentration of drug in the base. Basically, generally, we know the more the concentration of the drug you have in the base, the more you have available it will be for what? Absorption. So if you have more, that's why I say you can actually manipulate by looking at since when I was treating using lipophilic drug in fatty base, I say that since you know that only few small amount will what, if at all, you can actually work on the amount of drug in the what base, so as you can because the more concentration of the drug you have in the base, the more will be available for what? Absorption. I agree, but you get to a point, it will take more. there's a point it will take. There's a point it will reach. The more will not be worth. Excess will not be worth taking. So, if the concentration of drug, listen carefully, if the concentration of the drug in the intestinal lumen, you know what you mean by intestinal lumen, right? Lumen is above a particular amount, the rate of absorption is not changed. So if you like, increase the concentration, the rate will never change. It will remain what? The same. Now, this will lead us to what we call the rate limiting step. Listen carefully. Listen carefully. Remember in our tablets, in formulation, in compounding, what I said is the rate limiting step in compounding. In compounding, what I said is the rate limiting step. The most important step. This is right. Good. Now, hey, Chef Sigia. Is that what? Now, another point I want to make is this. Another question I want to ask is this. When it comes to drug disintegrating and entering the systemic circulation, what is the rate limiting step? Yes. No, it's not. The dissolution, God bless you. Dissolution, very important. If dissolution doesn't take place, forget it. True of us. Good. Now, I want to make a very important point here. In tablet and all those things, dissolution may be the rate limiting step. But in suppository, it's not dissolution. It's the partitioning. That's the rate limiting step. If the drug doesn't partition well, there's problem. True of us. I have told you the importance of what? Partition coefficient. Am I completing? So that's where we are going to now. In general, we agree in general that the rate limiting step in drug absorption from suppository is the, listen carefully, in general, the rate limiting step in drug absorption from suppository is the partitioning of the dissolved drug from the melted base. And not the rate of solution of drug in the body fluid, no. So it's not dissolution. It's about what? Partition of the already dissolved from the melted. So if the already dissolved is not well partitioned from the melted base, forget it, you will see a time. Are we together? Yeah. So that is the rate limiting step in words. If I laugh like this, take it seriously. Someone said that out of me. What is it you didn't understand? Tell me. Okay. What did I say about partitioning coefficient before? Tell us. Let's start from there. Let's even know where the issue came from. Feel free to tell us what we discussed. We have discussed this about 20 minutes ago. So tell us what you understood by what we said about partitioning coefficient as one of the properties as one of the factors, physical properties of the drug that affect absorption. What did you understand there? This is what I don't like in my class. I don't like this. I don't like people taking me back in my class. I don't like it. If I leave if I'm in a particular section, I ask, if you have a question, ask it immediately. You are taking us back to that place now, which is not fair. It's not what? Fair. These things are in particular divided into different what? Factors, sections. You are taking us to that factor now, which is wrong. And before I let the I ask question. If you don't understand anything, please ask. You keep quiet. Now we have mentioned we are taking us back that again, and I don't want to go back there. It's a waste of time. Before another person will take me back to the definition of suppository. Please, if you are in my class, please listen carefully. That's why anytime I enter your class, I need your maximum attention. Because once you do that, this, boom, before you turn, you are lost. You are what? You are lost. And that's one major problem most of you are having in my class. Some will be in class, but their mind is not there. They're not attending anything. They're just there, looking at food. So I'm confused. But they have a lot of things battling within them. She's taking us back to this thing now, to go and start explaining other helper.
The partitioning coefficient, talk about the people. He said that that's how drugs affect how it leaves the dosage form. And he said that the partitioning coefficient, we have the liquid, the fat soluble drug and the water soluble drug. That the fat soluble drug, when it combines with the fatty base, it will adhere to the drug. And it has fewer tendency to leak the drug. But when you use fatty drug and water soluble base, it can easily leave, although they are mixed together in that drug, but it can easily leave because it's fatty and water. They are not friends. Then we talk about water soluble base. When water soluble base mixed with water soluble drugs, it has two things are released. Both the water soluble drug and the fatty soluble drug, because of the rectal
Fluid, yes.
Because of the rectal fluid. That would be one that can release both. But when it comes to fatty, it's better you use water soluble instead of using fatty soluble. But when you want to use fatty soluble at some point, you measure the concentration, how many concentration of the drug you want to use fatty soluble or not for the thing.
Thank you. Now listen, let me drive it back. Can you keep that phone and listen? Drop that phone first. Hold your pen in your hand. That's how to be in my class. If you are in my class, hold your pen in your hand. Your book should be in front of you. Leave that thing you are reading from that chair. Leave that thing you're reading. That phone is with you all the time. Two of us. Get a go in a class. Leave it. Open your paper. Open your lecture notebook. Carry your pen. And be listening. As I'm talking, you are putting it down. Even though it's in your phone, you know it's your, leave it. Try to pull down whatever I'm saying. By the time you are done, you will be amazed that when you get to the hostel and get that to your phone you're looking at, you will see a lot of differences. You see some things you put down that is not in that particular material. That's why you need to be in lecture and on time. It's called lecture. In a lecture, some personal experience is shared. You can't expect me to start in trying to explain certain things, I may bring in an analogy that I didn't even prepare to use in a class. That's one mistake most of you make by missing your classes or being in class, your mind is not there. This lecture, just as some people will prepare the sermon they will preach in the church and they will man the pulpit, the Holy Ghost will take charge and they start talking something else. The same way it happens in academics too. I am telling you the reality. It happens in academics too. We have prepared the lecture material and gave you. Fine. But I'm coming here in trying to explain something to you. I may bring something else that is not even in the handout that we used to explain it. That if we are putting it down, it will help you to understand it better. But you will be in class, you will not be writing anything. You are just looking at what you have in handout. You are limiting yourself. That's one secret some of you people in this class have discovered. And that's why every quiz, they are scattering 19, 18. You know, you know, 10, 12. Some of you have discovered the secret. Do you want to be fool? I don't know how to put this thing in here, make it understand this. Even as I speak, some of you are not even with their pen. They not no material in front of them to put down some certain things. Even as I'm talking to you now. Hey, now, listen carefully. The point she made here now is that some drugs are soluble in liquid, in water, but they're not soluble in what? Liquid. Am I complicating? So, based on what you explained now, if you have a drug that is lipid soluble inside a fatty base, because it is lipid, it's hydrophilic, they have this, I use what you know, they hold each other, because it can't be released easily to the surrounding rectal fluid, because do you know why? Even the rectal fluid is even an enemy to it. True of us. He may bring out his leg to come and, it's our enemy, you go back and hold his friend to remain inside there. True of us. Because even the surrounding rectal is even an enemy to it. But the only friend it has is that base. It remains in that base. The release may not be that much. But if you use a solid, if a drug that is hydrophilic is formulated with a hydrophobic base or lipophilic base or fatty base, inside that drug, the what is it called? Inside the formulation, the drug and the base may not. Yes, they can miss because you force them to be together. But any slight difference, it can easily what? Escape. Because the rectal fluid will provide a kind of partitioning that it can easily enter the water and go its way. True of us. Now, inside the fatty base, we have liquid soluble, water soluble drug inside fatty base. Inside this is fatty base, you have water soluble drug inside the fatty base. This base is insoluble. But this drug, this one here is what? Soluble in water. And rectal fluid is there. Do you think it will depend here? It can easily, this and this are friends. It can go there and stay. Easily. True of us. This will melt. This can easily go there and stay. But if this drug is fast soluble, and which is not even soluble here, and this one is, this cannot leave this easily. But even apart from the fact that they are together, even the one here is even an enemy to the two of us. This is something of what happens in what? Partition. Now but if you have liquid, if the base is hydrophilic, like PEG, polyethylene what? Glycol. If it is hydrophilic, whether you have water soluble drug inside it or fast soluble, you can release it. Let's start from fast soluble. If fast soluble is inside here, the two of them are not even friends. So it's eager to let it go. So it can easily go and go its way. But if here, what we have here is water soluble, as I say, inside here is also what? Water soluble. So even though they can stay together, wonderful. But everything here can easily be dissolved by the two of us. Good. So that what happened. This last part of this last part, I'm not trying to tell you that the rate limiting step, the most important step for suppository now, is not just about dissolution, but the partitioning of this drug from the what? The melted base. That is the rate limiting step. If it doesn't partition, if the dissolved drug ends up not partitioning, it will not leave. Two of us. That's the problem. So that is how, if this concentration affect the water. Are we getting it? So please, don't this sound like a wonderful OBJ question. Now, generally it has been shown, it has been proven that the rate at which drug diffuses to the surface of suppository, the particle size, the presence of surfactant or surface active agents are factors that affect drug release. So apart from those ones you say, this one also what? Affect what? Drug release. Note them. Particle size, rate of diffusion to the surface of the suppository, and what? Presence of what? Surfactants. Let's move to the last part of this class so that your lecturer will come in. The last part says what? Physicochemical properties of the base and the what? Adjuvant. Of course, remember I said that the formulation has the drug itself. The formulation has the drug itself. Remember? Drug itself. Are we together? The base and what? And what? Adjuvant. Okay? Now, the base is singled out because of how important it is. But everything here is still what? Excipient. Hope you know. So other excipients are under what? Because they are there. They are there to enhance the absorption of the what? The drug. Are we together? Now we'll still talk about different adjuvants you can use. But it's not the topic for today. Now, the two factors are involved here. Nature of the base and presence of adjuvant in the what? Base. Nature of the base and presence of what? Adjuvant in the base. These are two physicochemical properties of the adjuvant and base that will affect the absorption of drug from the what? Suppository. So, now, what is the nature of the base? The suppository base, if it is the one that can do what? It can do what? Melt easily, soften, or dissolve as case may be. Then, it will affect the what? Release. True of us. If you all by ever quenching it will not melt. What will happen? Will it not come out? So the drug will not come out, right? So the ability to do what? Melt, and depending on the situation, either melt, dissolve, or the case may be, you can use the what? Release the what? Active what? Ingredient. Are we together? Yes. And that problem is this. Sometimes the base, we have people who have different reactions to certain things. Are you aware? Yes. The way you react to certain things may not be the way I react to certain things. There are some people that may be reacting to. Sometimes the base you use may even irritate the colon. Okay? The base may irritate the what? Colon. So if the base irritates the colon, see what will happen? It will bring a cascade of events that will lead to, it will cause prompt what? Colonic response. It will cause what? Prompt what? Colonic what? Response. So if there is, in the prompt colonic response is made clear in increase in the bowel. You know what bowel is, right? The GI, right? The GI, right? Movement. Bowel movement. Irritating the colon can lead to what? Bowel, increase in bowel movement. And if there is increase in bowel movement, do you think there will be absorption? It will decrease what? Absorption. It will do what? Decrease what? Absorption. So irritation of the what? The colon can lead to that. Can decrease what? Yeah. So if you know, if depending on the nature, what and what form the base, you know whether you can react to a particular set of what? Patient. Am I completing or something like that? Now, presence of adjuvant in the base may affect, of course. Now, when you have the other excipient in the base, it will definitely affect the what? Release of the what? The active what? Ingredient. True of us, it will. Because basically, most of the adjuvant are added to enhance the what? Release. True of us. So it will affect it. So, adjuvant in a formula may affect drug absorption. They even change the rheological properties. Example of rheological property, you talk about the consistency, the viscosity, how viscous it is, and these are some of the what? Rheological what? Property of the base. And the body what? Temperature. And it may also affect the what? Dissolution of the what? The drugs. So, any question? Ask. Yes, you can call it surfactant or surface activation. What? Sorbitol. You have sodium lauryl sulfate. Sorbitol. Okay. You can research more on examples of what? Surfactants. I think we'll stop here, right?
Yes, sir.
In our next class, huh? They're talking about experience. So in our next class, we'll look at what? What specifications of what? Suppository base. We have about 9 specifications. 9 specifications that will bring up the base to standard to be used as what? Suppository. You know, we can have don't worry, let me not take you there. We'll stop here. Thank you very much for your attention. God bless you.